And so with that, I'd like to take the moment to introduce an esteemed colleague of mine at the FDA. We have Dr. Callahan-Lyon, who's Senior Science Advisor at the FDA's Center for Tobacco Products, and it's my proud honor to introduce her to you all today. Thank you.
So good morning. I'm Priscilla Callahan-Lyon. Just by background, I am an internal medicine and pulmonary medicine physician, and I was in private practice for 20 years before I joined FDA. I currently am Senior Science Advisor at the FDA Center for Tobacco Products, and I'm going to give you a little bit of an overview of tobacco product regulation and an update on some of our more recent activities. So I'm going to start with the public health burden of tobacco, which you are extremely aware of. It's been very clear, but I thought this graph fit nicely with what was just said. And this was when the first Surgeon General report came out in 1964. And you can see that was kind of at the peak of the number of cigarettes smoked per year per capita. And as noted, we have made significant progress, so that's good. But also, as noted, we are not down to zero. So we still have work to do. This is a chart showing the current cigarette use as of 2020 in adults. And what you can see is that for adults, cigarettes are the most popular product, but adults do use e-cigarettes and other tobacco products. But even more significant, I believe, is this graph, which shows that the people in the adult population that use tobacco products are those that are at the highest risk, particularly those that are less educated, have less income, those with sexual minorities, those that live in rural areas, certain native populations, so the American Indian and Alaska Native populations. So clearly there is a lot of disparity among tobacco use. This graph here is the use of tobacco products among middle and high school students. Again, cigarettes is pretty low. If you look, cigarettes, it's down here, trending downward and down well less than 5%. In this population, the product that we are most concerned about is e-cigarettes, which you can see peaked around 2019. It is better in 2021 and 2022. Unfortunately, because of the way these surveys had to be collected due to COVID, you can't draw a direct comparison, but you can see that the trend is downward, though not as low as we would like, and it continues to be a problem. But just as with, just as with adults, the disparities are present in youth as well. Again, race and ethnicity, those with poor or with poorer grades in school, those with sexual minorities, those that are experiencing psychological distress, and those whose families are less affluent are much more likely to use tobacco products. So the FDA Center for Tobacco Products, I have our vision and our mission here. And basically what we are doing is focusing on making tobacco-related disease and death a part of our past, not of our future, and ensuring healthier life for every family. The Tobacco Center, or Center for Tobacco Products, was started after Congress passed the Tobacco Control Act in 2009. That act gave FDA the authority to regulate the manufacturing, distribution, and marketing of certain tobacco products. And in 2016, we extended this rule to cover more tobacco products, including e-cigarettes that were contained nicotine or that was made or derived from tobacco. In 2022, Congress recognized that we needed to change our definition of a tobacco product, and they changed the law to allow us to regulate tobacco products containing nicotine from any source, including synthetic nicotine products. So the Tobacco Control Act gives us authority to do a lot of things, including pre-market review of new and modified risk products. We can do post-marketing surveillance. We can write product standards. We can require the reporting of harmful and potentially harmful constituents and adverse event reporting. We can come up with new warning labels. We can have advertising and promotion restrictions. And The Center for Tobacco Products is funded entirely by user fees. These are paid from the industry based on market share, not applications. I will note, however, that e-cigarettes, which were not in existence to any great degree when the law was written in 2009, makers of e-cigarettes are not required to pay these user fees. So that's something that is a significant problem, because a lot of our resources are directed towards regulating and attempting to control the use of e-cigarettes in this country, but the products manufacturers are not required to pay user fees. We're working to get that changed, but we haven't gotten there yet. It's important to know that there's certain things that are not within our authority. For example, we can't set the tax rates. We can't regulate therapeutic products. Those are regulated by other parts of FDA. We can't set an indoor clean air policy. We can't regulate the growth of tobacco. We cannot require the reduction of nicotine yields of tobacco products to zero. We can require a lower level of nicotine, but we can't make it zero. We can't ban everything. That would be nice, but it's not allowed. And we, as the Center for Tobacco Products, cannot change the minimum age to purchase tobacco products. So what are we focused on? We focus on tobacco product application review. We do focus on compliance checks, and particularly looking to see whether or not that the manufacturers and retailers are following the law. We focus on education, particularly towards youth, and also on rules and guidances. The Center for Tobacco regulates products by looking at the net public health impact. We weigh the likely benefits and risks of the product. We recognize that there is no such thing as a safe tobacco product. We don't look at whether or not the product is safe or effective for anything. We look at whether or not that marketing of the product would be appropriate for the public health, focusing on the users, the non-users, and the public at large. Now, there could be some confusion because, as you know, there are nicotine products that are marketed as a therapeutic product. So our focus is on products that are made or derived from tobacco, as well as those that contain nicotine from any other source, such as synthetic nicotine, that is intended for human consumption. And it does not focus on medical products or products that are intended for disease mitigation or prevention. We have a jurisdiction rule that helps define what is a tobacco product and what is not. We do look at modified risk tobacco products. That's products that can be sold or distributed to reduce the harm or risk of tobacco-related disease, but these products are still tobacco products. They are not intended to be safe and effective for treatment of a condition. They don't act to mitigate, prevent, or otherwise treat disease. I'm going to move now to product standards. So the product standards have been mentioned earlier. And what is the product standard? A product standard basically is a rule. This is one of the strongest authorities that Congress granted us. So what FDA can do is propose a rule, and we have proposed two, which I'll discuss in a little bit more detail. When we propose these rules, we have to provide significant scientific basis for the reason for the proposal and what benefit, both from the scientific and the medical standpoint, as well as an economic analysis for the rules and what will happen when the rules take effect. Once the rule is published as a proposed rule, then there is a public comment period. And during that time, the public can comment. This can be any member of the public, individuals, researchers, academicians, the industry, anyone that wants to can comment. And during the comment period for these two proposed rules, we received over 250,000 comments. FDA is required to consider every single comment. After we have considered the comments, we can then decide whether we're going to rewrite the rule, whether we're going to modify the rule, or whether we're going to propose a final version of the rule. So right now, with these rules, we're at this stage right here. So we've proposed two product standards. One of them would prohibit menthol as a characterizing flavor in cigarettes, and the other one would prohibit all characterizing flavors except tobacco flavor in cigars. With these product standards for cigarettes, we're hoping to reduce the appeal of cigarettes, particularly for youth and young adults. The youth that begin smoking cigarettes are almost always inclined towards starting with menthol cigarettes. The menthol reduces the harshness of the cigarette and makes it more palatable, particularly for an early smoker. We also want to reduce the mortality risk among menthol cigarette smokers. If you noticed when Norma was showing her pictures, she had multiple pictures of cigarettes, and almost all of them were of menthol cigarettes. Menthol cigarettes are much more commonly used in the African American population, as well as other groups that are already victims of health care disparities, and this is aggravated by the availability of the menthol cigarettes. We also know that over the years, the tobacco industry has focused heavily on advertising and marketing menthol cigarettes to these populations. By prohibiting menthol in the cigarettes, we hope to increase smoking cessation among these groups. The flavored tobacco or the flavored cigar product standard hopefully will reduce the appeal of cigars, particularly among youth and young adults. So when the 2009 Tobacco Control Act was written, it prohibited the flavor in all cigarettes except menthol and tobacco flavors. What happened, because cigars did not fall into that category, was flavored cigars, which previously there were flavored cigarettes. Now flavored cigars have taken off, and there are multiple flavors of these cigars. So making these cigars so that they can only be tobacco flavored hopefully will decrease their attractiveness among youth and young adults and increase smoking cessation among the cigar smokers. We've also publicly stated that we intend to propose a product standard that would establish a maximum nicotine level to reduce the addictiveness of cigarettes and other combusted tobacco products. The hope is to publish this proposed product standard within this calendar year, and it would go through the same rulemaking process that the menthol and cigar flavor rules are going through at this time. FDA has several tobacco prevention campaigns. Our tobacco prevention campaigns have been largely focused on youth, but there are those that focus on adults as well. As part of our campaigns, we do base these in science, and we also monitor what the effectiveness of the campaigns is. So we have, by the scientific evaluation, prevented over 500,000 youth from trying cigarettes, and many of these would have been smokers eventually. We calculate that we've saved more than $180,000 for each youth that has been prevented from becoming an established smoker. And this should eventually lead to saving over $53 billion in terms of smoking-related costs, such as medical care, lost wages, and increased disability. So we think that the campaigns are highly effective. We do have campaigns directed for youth, and we've had a couple of new campaign ads that have come out recently, focusing on mental health effects of cigarette smoking and withdrawal. So those ads are very effective. One of them is geared towards the mental health effects of cigarette smoking and cigarette withdrawal, and the other one is geared towards anxiety. And they both are very effective. You may not have seen these ads initially when the Real Cost campaign ads were coming out directed towards e-cigarette use in youth. These were on TV, but in recent years, we've learned that kids don't really watch mainstream TV anymore. So most of the ads now are broadcast on social media, where kids are more likely to see them. We also have a tobacco prevention campaign that came out last year, about a year ago, specifically directed towards Alaska Native and American Indian youth, called Next Legends. This campaign as well is largely digital. It is broadcast on live TV in certain areas of Alaska where internet access is not as common, but it focuses on these particular communities, and these particular campaigns were developed with input from the American Indian population. I did want to focus just for a couple minutes on cessation interventions and the continuum of risk. This is an area that I think has been mentioned to some degree earlier by Dr. Friedman, and we do acknowledge that there are a lot of questions these days with regards to continuum of risk. As has been noted, the combination of tobacco cessation medications, such as the nicotine replacement products and varenicline and bupropion, with counseling is the most effective way for us to help people quit smoking. There also is a brain stimulator that has been authorized by FDA that is helpful for short-term smoking cessation in adults, but it's not widely available yet. There are tobacco products, however, that we have authorized, and I want to emphasize that CTP does not approve tobacco products. We don't approve of any tobacco product. We do authorize the marketing of tobacco products that we believe could potentially be appropriate for the protection of public health, in that they do have a lower level of risk compared to combusted cigarettes. There is no tobacco product that is safe, but we do believe that there are some tobacco products that are less risky. The idea with these products is that they will help smokers smoke fewer and hopefully no cigarettes and move them down the continuum of risk. Obviously, the ultimate goal is complete cessation of all tobacco products, and combustible products we know represent the greatest risk on this continuum. I will note that there have been no electronic products that have been authorized by FDA as a therapeutic product, but we have authorized marketing of 23 electronic cigarette products as appropriate for the protection of public health to help adults reduce and quit smoking. As part of the product standards, we are focused on trying to provide a cessation care package. I really was quite gratified to hear about all the work that's being done through your clinics in Los Angeles, which are already have in effect many of the things that we have been focusing on across health systems. So one of them is things that are being done is focusing on the populations through our product standards. This is the part that CTP can do. The individual therapies, the pharmacotherapy, the behavioral counseling, and even digital health tools, which have been shown to be of benefit in certain populations. The advantage of the digital health tools, this is apps and things that people can have on their phone, is that they can be very personalized to the individual user or the individual population. But there's still quite a lot that needs to be done in regards to health systems, barrier-free access to treatments. Clinical practice guidelines are out there, but a lot of them are not followed consistently. Clinician education and resources are a major issue, particularly in certain communities. The cessation care package should focus on every member of the clinical team participating. Most patients need multiple tries before they successfully quit cigarettes. As has been noted, they have to be ready to quit, but they also almost always have to try several times before they succeed. So having everyone in the team involved in participating and assisting these patients can improve the efficiency and support this approach. You're all familiar with the 5 A's, I'm sure, and this is a proven method to help assess and evaluate and assist patients in quitting to smoke. We also have at FDA the Nicotine Steering Committee. So this is an FDA-wide group that was started in 2017 by Dr. Gottlieb when he was commissioner. This group continues to meet on a regular basis, and we've had a lot of activity over the last few years, focusing primarily on e-cigarettes, but also on trying to work to develop a full cessation package as these product standards hopefully will go into a final rule phase later this year. There's a recognition that we need better products or new products focusing on helping people quit smoking. We haven't had a new smoking cessation product approved through FDA for quite some time. So we have worked with our Center for Drugs on trying to come up with ways that we could improve and facilitate the development of therapeutic products that would give us more options for people. So we recognize that it's very important to ensure that there's broad and equitable access to effective and affordable tools, to resources that can help smokers quit, particularly those that face the greatest health disparities and the barriers to cessation. This group here, those that face the health disparities and the barriers to cessation, are the ones that are much more likely to actually still be smoking cigarettes, which are the most dangerous products that we can have people use. As was mentioned first a few minutes ago by Dr. Nakasi, we've made a lot of progress, but it continues to be an ongoing effort, and we lose 500,000 people a year just because of cigarettes. So what can we do? We do have tobacco cessation resources. FDA has resources that are available through our website. We have a variety of posters and other materials that are available. They're available focused on different populations, adult smokers, the LGBTQ community. They're available in Spanish. And these are available through our digital media website. You can download them, you can print them, you can send us an email and we will send you versions of them. There's a lot of these resources that are available, and they're available to anyone that asks. We also work heavily with partners, and this was actually mentioned earlier in Dr. Friedman's talk. He mentioned the work that California and other states and territories and localities did with regards to the Tobacco 21 law. As was mentioned earlier, this was signed into law in late 2022, but many areas of the country already had the Tobacco 20 law in effect. So the efforts that those states, territories, and areas undertook to enforce that across the country made it a lot easier for us to show that this would be of benefit in reducing youth tobacco uptake. So thank you. This work across multiple jurisdictions allows us to provide greater levels of protection and allows us to provide the support and the scientific evidence that we need to collaborate and complement the work and preserve our state and local authorities, as well as help us at the national level. So these are very, very important collaborations that go on across the country. The state and local efforts identify and test and refine certain methods for preventing and reducing the harms of tobacco. The Tobacco 21, as I stated, is one effort that was an example. We also work as a resource to provide and complement both the state and local and tribal level efforts, as well as with CDC. All of us need to work together to provide the support to each other and also to provide to healthcare providers to facilitate tobacco cessation. We do a lot of work with researchers, and we also encourage people to submit comments when we propose rules. This will help make your voices heard. The other place that people can help is by reporting to our safety reporting portal. These firsthand reports can help us stay on top of issues. I'll give you an example of that. It was several years ago when we had multiple reports related to seizures in youth that were using e-cigarettes. And this actually led to us issuing a report to the public, encouraging the further evaluation of that. We still do see occasional reports of seizures related to the use of e-cigarettes. We don't know exactly what the association is, but it's definitely something that we need to be aware of, and we need to continue to receive these reports so we can stay on top of it. So I'll summarize by saying that while cigarette use has declined substantially, the decline has not been experienced equally across the landscape, and we need to continue our efforts to make sure that all populations can continue to see the benefits of stopping smoking. CTP is working to achieve our mission by issuing rules and guidances, by reviewing these pre-market applications for tobacco products, by taking enforcement actions against those that violate the law, and by educating the public on the harms of tobacco products. We are working on several initiatives to reduce tobacco-related disease and death, including landmark rules and public education campaigns, as well as resources to facilitate cessation. And I have included our contact information as well as our safety reporting portal link for reporting any adverse experience related to a tobacco product. And these reports can be submitted by anyone. It doesn't have to be by a researcher, can be by a member of the public, by a clinician. Anyone that wants to submit a report is able to do so. And with that, I will stop my sharing. I don't know whether you want any question time.
We go to the first questions. So someone had asked, why not cigars? And then, but I'm not sure what that was pertaining to.
Okay.
There was a question, where does clove cigarettes fall into this continuum, and has its properties been studied in terms of effects on smokers who smoke them?
So clove cigarettes that only contain clove would not fall under our regulatory authority because they don't contain nicotine or tobacco. So they've not been evaluated in the continuum. However, I will say that if they are a combusted inhaled product, then I think common sense would tell you that they are not a good idea.
And then, are there ads that are geared towards LGBTQ plus youth?
Yes, there actually has been a couple of different campaigns specifically geared towards that population of youth, and also some of the posters that we have available are also geared towards the LGBTQ community.
Sounds good. And then, could the doctor address the value of group meetings that meet in person and how counties can get funding to train these facilitators to provide the group classes?
I'm not the right person to ask about funding, I'm afraid. I think in terms of counseling and behavioral therapy, I think we know that behavioral therapy and counseling services are extremely beneficial. I think the advantage of group over individual counseling, I'm going to have to defer to somebody that knows more about that than I do. I don't know if there's any specific literature out there on that or not.
Okay.
I'll also answer that question, that we are submitted a grant to TRDP that we'll hear back in April. Hopefully we'll get funded to expand tobacco cessation training throughout Los Angeles. We expect to have multiple different types of training to different types of providers, mental health experts, counselors, and all those to improve, to provide smoking cessation training throughout California, including group effects.
Yes, so that would be throughout California. And then another question, does the doctor recommend a specific smoking cessation curriculum in use now?
In youth or in use? I'm sorry.
In use.
In youth.
Use. Oh, use. U-S-E, sorry.
Oh, use, in use. Okay. Do I recommend a particular curriculum? No, I don't recommend a particular curriculum as such. There are quite a few things available across the country, and what I've seen in the literature that I've seen is that those that focus on particular populations seem to be effective within that population. So, for example, at the Society for Research on Nicotine and Tobacco meeting that I attended earlier this month, there was a presentation on a program that had been developed specifically directed for African-American adult smokers that had dramatic results in that particular group. But what they had done was take a traditional program and change just some of the language, focusing so that it was more culturally appropriate for that particular population. And that really made a big difference. But it was a very small study, and very local. So I think that sort of information, what I got out of that was that programs, and particularly these phone apps and other things that can be personalized and directed towards particular populations, can be extremely effective within that population. But what works for me probably isn't going to work for somebody that's in a completely different cultural situation than I am. And
Okay.
Norma, I see you unmuted. Did you have something to add on that one?
Yes, later on today, you're going to hear from our behavioral health specialist on our team who does training, and we have developed a curriculum through this project. So if you hang out, you'll be able to hear and see what that curriculum looks like.
And then another question is, what does our society need to help with reducing smoking to zero? More funding, more classes, more facilitators?
Yeah, that's a really good question. I'm sure money would help. Money always helps. But in terms of to reduce smoking to zero, I think the Center for Tobacco is limited. We can't make it illegal. That's part of the way the act is written. But I think continued education, continued efforts, continued work towards making it so that people realize the dangers and I think those are going to be our best effort. I don't know that there's a one single answer that's going to solve the problem. I think if it were that simple, it would have been solved decades ago.
Mm-hmm. And so the last question that I will have, so someone was asking about training specific to Los Angeles or California, like Dr. Friedman said, hopefully we'll have that in the future. And then someone asks, are there cessation curriculum that address the specific needs of the LGBTQ plus tobacco users, especially transgender folks who are denied gender affirming care due to any nicotine use?
I'm sure there must be. I do not know specifically what they are. I know, in terms of those that are denied care, that's a very niche group. And I don't know of a particular program that is specifically directed toward that group, though it is a problem.
Okay.
And there was another question I saw in there about no e-cigarette or vaping products have been approved for smoking cessation, but have been approved. They haven't been approved for anything. We have authorized the marketing of them. So they're not approved.
And I believe other people in the chat answered all of the other questions. So I think that will be it.
Okay, very good.
Thank you so much. Great talk, Dr.
Okay.
Callahan.
Thank you.